Hello everyone, and welcome to the Healthier Here Partner Learning webinar. It's high noon. We're doing our best to start on time, and we're really glad you could join us today. This is Mary Magliola Franzen, and I'm here with Tavish Donahue. Tavish and I are both members of the Clinical Practice Transformation team here at Healthier Here, where this is the fourth in our Partner Learning webinars. Today is harm reduction for substance use, meeting people where they're at. As we go along, Tavish is going to be keeping an eye on the chat, answering questions when she can, and other than that, we will be holding questions probably until the end. We do encourage you to chat the questions throughout. We will get to them, but the way today's structured, I think we're going to be holding them for a bit. So I'm going to turn it over to Tavish for a second just to explain the process of how you chat things in and talk to us.
Okay, so welcome everybody. Yeah, we're so excited to have so much interest in this webinar. The GoToWebinar software may be new for some of you who haven't been a part of Healthier Here's webinars before. So we're just going to show you a couple slides on logistics, how to ask questions. So you'll see a little orange arrow. That's how to expand kind of the panel on the right, where you will see chats and answers to questions if you ask them. So you'll see a questions box. You can expand or collapse it. If you have any questions that come up throughout the webinar, please type them in, and those will come directly to me. And at the end of Dr. Collins' presentation, we'll be opening up the floor for questions. So then I'll be asking some of your questions. So that is how to type in a question. This slide shows if you would like to speak your question, you can do that. You're going to click the little hand icon to raise your hand, and then I would be able to unmute you to have you ask your question of Dr. Collins at the end. But if you are going to ask your question and you've dialed in on phone, it's very important that you enter in your audio PIN. So on this slide, you can see how to do that, to enter your audio PIN so that I could unmute you. Are we good?
All right, so thank you, Tavish, and a big thank you to Dr. Susan Collins of the University of Washington, who is our presenter today. And I'm just going to turn it over to Dr. Collins right now, who will introduce herself and get us started on today's webinar.
Hi there, welcome everyone. Thank you so much for introducing the webinar today. My name is Susan Collins. I'm a licensed clinical psychologist, associate professor at the University of Washington, and at Harborview Medical Center, I'm a clinician. I lead the harm reduction treatment track, and I also co-direct together with my colleague, Dr. Seema Cliffoseppi, the Harm Reduction Research and Treatment Center here at UW Harborview. And today I'll be sharing information about harm reduction treatment for substance use. I'll actually start out more broadly defining what harm reduction is, because as I'll mention, it's a big tent. So there are many different kinds of practices and tools that can fit under the definition of harm reduction. I'll talk about what that looks like in practice when we're practicing on various levels of harm reduction intervention work. And I'll provide a rationale for harm reduction treatment and different approaches. I'll kind of hone in on what is harm reduction treatment as well, which is the practice of harm reduction on the individual level. So oftentimes I start, in person when I do this presentation. I'll ask folks what comes to mind when they think of harm reduction. For the purpose of the webinar, I like to just provide a bit of a collage so you can start to understand. As I mentioned, it's a really big tent, so there are many different kinds of approaches that could be classified as harm reduction approaches. And today we'll talk about the range of those approaches, from really broad scoping policy approaches all the way down to how we talk to individuals on the level that you might be engaging in harm reduction practice on a daily basis if you're a clinician, a counselor, a case manager.
Hi, Dr. Collins. So sorry to interrupt, but our audience is seeing the presenter view of your slides, so the slides themselves are small. If you go up to the top and click Display Settings, and then do Duplicate Slideshow.
Okay.
Try that one.
Great. Okay. Well, thank you. Thanks for letting me know. Fortunately, I don't need...
We're in business. Thank you.
So to start off with a broad definition of harm reduction can be described as a set of strategies, as I mentioned before, a really big tent. It is defined as a grassroots and user-driven set of compassionate and pragmatic approaches that aim to reduce substance-related harm and improve quality of life without requiring abstinence or use reduction. So that would be the key that differentiates it from other, potentially patient-driven approaches or patient-centered approaches. But it really is the attitude or the approach or the spirit with which we are engaged in harm reduction that counts more. And that was even pointed out by the late and great David Purchase, director of the North America Syringe Exchange Network. You know, for David, who was handing out at first needles and later syringes over a card table back in Tacoma, Washington in 1988, he was someone who really dealt in the nuts and bolts of the actual devices that would help people engage in substance use more safely and avoid substance-related harm. But even he believed it really is the spirit with which he was engaged in that harm reduction practice that was the most important part of how it was being delivered. So our philosophy as harm reductionists is compassionate. We acknowledge that substance use has both pros and cons, so we don't negate the very real negative consequences that some people experience due to substance use, but we also acknowledge that people use for a reason. They use for real reasons, and substance use isn't crazy or irrational, but people are really getting something out of substance use, otherwise they wouldn't come back to it. It's important for us to acknowledge that as clinicians for a few reasons. Some of them are very pragmatic reasons, right? So acknowledging that helps us connect with our patients, helps us build a better therapeutic bond. But it's also important for us to think about it in terms of helping patients begin to imagine alternative pathways to being able to achieve those positive things that they expect usually from their substance use behaviors, or to be able to get what they want out of their substance use, but be able to avoid a lot of the negative consequences or the cons that they're experiencing. We also acknowledge that substance use is here to stay. So instead of trying to use our precious time as clinicians to try and eradicate an essential human behavior that's been around for millennia, instead we can focus on what can we do to help this individual and their families, their communities, reduce their substance-related harm today. We acknowledge that substance use is complex. We often talk about substance use and substance use disorder as a behavior and then a disorder that resides within the individual. But we need to acknowledge from a harm reduction perspective that substance use exists in a larger social context, and that individual choices around substance use are part of what drives substance use in our society. But there are larger familial, community-wide, and even geopolitical forces that determine what kinds of consequences people will experience due to substance use and how their substance use is viewed by others. I think it's really important for us to think about that regularly, that most of how we understand what is substance use, what is illicit substance use, what is legal, what is well looked upon, what is not so well looked upon, is a social construction that has throughout history changed depending on the culture and the specific point in history. I think for those of us in Washington State, that is very clear to us. Only, a few years ago, we were talking about cannabis use as an illicit substance use behavior. Now it's much more acceptable in this state. And so understanding that these are social constructions about how we view substances and that we need to take that into account as we're thinking about substance use. Nothing is black and white or absolute. And I think this is important for us to consider also on the diagnostic level. So for those of you who have been through multiple versions of the DSM, for me, it was quite shocking to go from overnight running large-scale randomized controlled trials and studies and seeing patients and doing billing, that overnight things I had been diagnosing people for and either including or excluding people from large studies for, poof, disappeared, right? So when we moved out, suddenly there was no alcohol dependence. We were talking about alcohol use disorder. So things that feel really concrete and have concrete consequences for our patients based on the labeling that we put on them can change, shift and change over time. So these are just important things for us to consider, is that the boxes we place people in, while sometimes useful for billing purposes, change the way that they're viewed and their substance use is viewed. And so it's important then to kind of extend that out to remember that substance use is not the client and the client is not solely their substance use. This doesn't define a person and who they are, certainly not in their entirety. But if we start to really think about substance use as quite simply a behavior that a person is engaging in, while acknowledging that there's so much more to this individual, that really helps us to humanize the folks we're working with and be able to attend to all of their needs and not just hone our focus in on their substance use behaviors. Oops. Our approach as harm reductionists is also pragmatic, so we are not talking about use reduction, and I'll mention that a few different times throughout this talk. That is on purpose. Sometimes harm reduction has been conflated with, for example, moderate drinking. Really, we try to avoid talking about the absolute level of substance use as the outcome, although an individual might decide that that is what their harm reduction goal is, and we would get behind that as a clinician. We as clinicians don't try and define harm reduction outcomes as quite simply use reduction outcomes. And I'll talk a little bit about why, the rationale for that in a few minutes. Our focus in harm reduction is, of course, about reducing harm, so we do have an agenda, but it's also really focused on quality of life. And that's important because when we're talking about what people want to leave behind or what they want to shed, we also need to be focused on what people want to move towards. That might sound common sense from a clinical perspective, but we're also finding in our research that we find like a 50-50 split when we ask people what they want to see happen for themselves in harm reduction treatment. So about 50% roughly are interested in attaining certain kinds of substance use goals for themselves. It could be reducing their experience of blackouts. If they're drinking alcohol, it could be reducing their risk for overdose or reducing their absolute use or even attaining abstinence. But for the other 50% of folks, people are really focused on what they want to engage in, becoming more engaged in meaningful relationships and activities. And we find that the more people are engaged in meaningful activities, the more their substance use tends to decrease in accordance. So we really not only want to focus on quality of life because it's, sounds like a clinically important thing to do, but it also seems to bear out in the research that that helps us achieve our parallel harm reduction goals. Harm reduction is client-driven, not simply client-centered. So the clients do drive the agenda in terms of what are the outcomes that are most important to them. And harm reduction is open to the power of any positive change. So oftentimes for those of us who are mainstreamers, who have homes, for example, 9-to-5 jobs, we have certain sets of values. They might come from our cultural backgrounds, from our familial backgrounds, from kind of our position in our socioeconomic status. And we need to acknowledge that these might not be the values of the person sitting across from us. So for us to be able to adopt the values of the other, essentially, and to be open to the power of any positive change as they see it. So what might look like baby steps to us might be huge leaps and bounds for the person sitting across from us, or what might not even occur to us as a positive change step might be very important given the value set from the person across from us. So being able to really understand and acknowledge the power of any positive change as the client or the patient is defining it. And our role as harm reductionists also, we really need to engage in advocacy for social justice and racial equity. And this we can do by helping our patients and our clients learn about how to self-advocate within the system. I often, in the Seattle area, refer folks to the People's Harm Reduction Alliance, which is a user-run nonprofit organization that provides safer use equipment as well as information and a sense of camaraderie to help people advocate for themselves to have rights to equal rights to healthcare interventions and safer use equipment. Also in the Seattle area, Vocal of Washington, which is an offshoot of Vocal of New York, is a great way for marginalized substance users to be able to connect with legislators and have more power over how their community is treated and equal rights to healthcare and access to housing. And it's also about us advocating on behalf of our substance using patients and clients to our colleagues. So not engaging in that sense of gallows humor that I know we say sustains us, because what that ends up doing is dehumanizing a lot of our patients. So really helping our fellow coworkers understand the humanity and the full spectrum of a personhood that is behind substance use behavior. And this is really important because in harm reduction, communities have been engaged in harm reduction for, probably since the dawn of time. In the modern harm reduction movement, this really was a grassroots-led movement that should continue to center the voices and the interests of substance users, people who use substances themselves. Because for those of us in the medical professions and for those of us in public health professions who are starting to get excited about harm reduction, we weren't really there for substance using communities back when they were advocating for our attention and trying to get attention paid towards the HIV/AIDS crisis, for example, in the early 80s, that was affecting disproportionately certain communities, and throughout the 90s. Even thinking about trying to get lawmakers' attention up until 2009 when then President Obama finally struck down the federal ban on use of federal funds for needle and syringe exchange. So thinking about how, we have really neglected the needs of these communities for many years, and it was them who stood up and had their voices being heard at great cost to themselves oftentimes, and for some of them costing their lives. And so really acknowledging that these movements started in communities, oftentimes marginalized communities of color, acknowledging that things such as mass incarceration of low-level drug offenders have disproportionately affected communities of color and torn apart families. This is really important for us to acknowledge as we move forward so that we can, lift these communities up and help these communities versus get in their way as they're moving towards harm reduction. So what does harm reduction look like in its application? As I alluded to before, harm reduction can be practiced at various levels, so we can engage harm reduction interventions at various levels of practice. And as a harm reductionist, we should actually want to be engaged on all of these levels at different times. So even if we're working on the individual level, for example, we do in our research and in our clinical work here at the University of Washington, we also want to be then using these data that we collect or our clinical experience to influence, sorry about the sirens in the background, I clearly am working in a medical center, but we want to use these data and we want to use our clinical expertise to influence policy at the larger level. And we've been able to do that actually in Washington State. Some of y'all might have heard that House Bill 1768 has passed unanimously, the House and the Senate. That was something that we used our research to help influence language around the definitions of chemical dependency counseling to relax its heretofore focus on abstinence as the primary goal of chemical dependency counseling, and instead focusing on recovery, however that should look for the individual. This was really huge, and working with legislators to who have that kind of leverage and that power. We worked with Representative Lauren Davis and Representative Nicole Macri most specifically, but leveraging the data we had so they could move forward with opening up the treatment spectrum to attend to the needs of more than just individuals who were ready, willing, or able to seek abstinence, really can change the course of substance use treatment in Washington State moving forward. So that it really is something I want to reinforce, is that even though we might be working in our day-to-day on the community level or maybe on the individual level, we need to have our eye towards how can we use the work that we're doing on these levels to influence other levels and to broaden out the impact that harm reduction can have for communities in a good way. So what does harm reduction look like, for example, at the policy level? That would be an example. Obviously, House Bill 1768 would broaden what kind of treatment goals treatment centers can be focused on. So instead of just insisting upon abstinence or abstinence-only treatment centers, that could broaden out to include harm reduction as goals. More classically, you can think of decriminalization, legalization, and regulation of what are currently considered illicit substances as a policy-based intervention aimed towards harm reduction. And this is important to consider right now, just considering the overdose crisis. The primary reason why people are getting very sick and dying in this current crisis is because people are not able to understand what kind of dose they're getting on the streets. So even black tar heroin, for example, these days is laced with fentanyl. They've figured out how to spray it on. And the fact that people don't, because it's an unregulated industry, the illicit drug trade, people don't know what kind of dose they're getting, and that really is what's driving the overdose crisis these days. Is the unknowns involved in synthetic opioid production. The other main reason why people are getting sick and dying is because people don't have access to clean use equipment, and this can cause to lead to reusing needles or sharing needles if people are engaged in injection drug use, which introduces bacteria, in some examples, abscesses if people are reusing duller needles, or in sharing, obviously, the transmission of bloodborne illness. So really thinking about policies that we can introduce to decrease overdose writ large is really important as well. In terms of population-based harm reduction interventions, one example that I often talk about liking the most is a population-based intervention from the 80s, Friends Don't Let Friends Drive Drunk. It really changed the way we thought about alcohol use and driving in this country back then. And this was very much driven by the grassroots organization Mothers Against Drunk Driving. It was a commercial created by the Ad Council. And in this commercial, there are two mugs of beer that in slow motion are moving towards each other with squealing tire sounds in the background. And then they burst into each other and explode. And then the tagline is Friends Don't Let Friends Drive Drunk. And so this is a population-based intervention. It's a public service announcement, if you will. It wasn't something that was targeted just towards substance users or just towards people who were drinking, but rather trying to inform an entire population about the relative risks of engaging in certain kinds of behaviors around substance use. So the idea wasn't don't drink on a Friday night, but if you do go to the bar and drink on a Friday night, please don't drive home. And that is essentially a harm reduction message that was transmitted to change the behaviors of an entire population. Example of community-based harm reduction intervention would be things such as needle and syringe exchange, low barrier housing that allows use on site and provides safer use equipment. So the housing first model of housing, for example, permanent, supportive, low barrier, non-abstinence-based housing. Things like safer consumption sites. These are all interventions that are administered for a specific community, but that also reduce harm for the community right around that community as well, particularly in urban centers. And where most of us are practicing in terms of case managers, counselors, clinicians, providers, on a day-to-day is going to be this individual level, this final level down here. So what does that look like? So applying this larger harm reduction philosophy or mindset that I've been talking about up until now to the individual level is what we've started to call harm reduction treatment. And that really comes down to how we talk to people. And we think harm reduction treatment is really important for us to consider for those of us working in harm reduction on the individual level, because we have really great tools, very efficacious tools these days, devices, medications that are aimed to reduce people's substance-related harm. But if we as clinicians, providers, and counselors aren't speaking to our patients and our clients and community members in a way that parallels the harm reduction intent of these devices and medications, it creates a real disconnect for our patients. It's a confusing message. So for example, methadone and Suboxone are opioids, right? And they are administered, they are more controlled opioids that are at lower doses and more dependable and reliable doses, obviously, than opioids that are bought on the illicit market. They are safer. For example, Suboxone bonds more efficiently to opioid receptors than, for example, heroin or fentanyl. So it can actually avoid opioid overdose if other opioids are on board. But it also, Suboxone and methadone, reduce craving and reduce withdrawal symptoms of opioid use disorder and maintain people at a lower dose of opioids so they can return to their lives. So this certainly isn't a method that's abstinence-oriented, right? It's not meant to get people off of opioids, but rather have them consuming opioids in a more controlled dose so that they can regain functionality in their lives and potentially reduce their substance-related harm should they continue to use other opioids. Naloxone is the opioid rescue drug. So if people overdose, it can revive a person and reverse that overdose. Clearly not meant to have people stop using substances, but to bring them back to life, obviously reversing one of the largest and most imposing negative consequences of substance use. Vivitrol for alcohol use, reducing craving for alcohol. So it isn't something like antabuse that makes people sick if they use alcohol, but it helps people reduce craving to get time and space maybe away from their alcohol craving so that they can make more positive choices for themselves. And most recently, I would say electronic cigarettes, which, you know, if people switch to electronic cigarettes or any kind of smokeless tobacco, you know that people are automatically 85% safer than if they're smoking cigarettes. So this isn't meant to have people stop using nicotine. It's meant to help people use nicotine more safely. So these are all devices and medications that have become, in some cases, like Suboxone and methadone, the gold standard for substance use treatment as treatment of substance use disorder in this country. But if we're continuing to talk about abstinence only as an approach, we're really not speaking to these devices and what they're meant to do and medications in a way that's congruent. So our harm reduction counseling that can ride really well alongside these medications and pharmacological adjuncts comprises using this harm reduction mindset that I've been talking about to date with a really compassionate spirit. You can imagine it sort of as a motivational interviewing spirit applied towards a harm reduction end. And then we use 3 concrete components that we use in sessions with patients. First, we do a very elicit a story around people's substance use. What substances are you currently using? What else? Eliciting stories around how people use, what is the drug set and setting for all of the substances in the mix. And then also assessing their substance-related harm and helping them track those over time in a really transparent way. And also asking people what they think are the most important metrics in understanding what substance-related harm looks like for them. So we're involving them in the conversation of how do we know that we are successful as harm reductionists in session with them. And having people track what are their priorities over time is actually really helpful. And the reason why we do this is because we co-created these elements together with people with lived experience of really severe social marginalization and substance use. But what people said was they didn't like how we as providers and clinicians often have this black box of EHR, and we're monitoring people and taking in numbers all the time, but they don't really understand what that means. And we might not be, assessing quote unquote treatment success on the same metrics that they would understand success. And so really involving them in that conversation and helping them track their key metrics that would determine harm reduction for them over time has been important to many of our patients in a harm reduction treatment context. We also elicit and have ongoing discussion of people's harm reduction goals. We elicit those by simply asking people what they want to see happen for themselves. And what we found, again, is this 50-50 split. About 50% of the goals that people come up with are based on substance use and wanting to reduce substance-related harm. And the other 50% tend to be these quality of life-related goals. And we find, again, when people are really connected to things that are meaningful, and if we are helping to support them in the pursuit of these intentions or visions that they have for themselves, that their substance use tends to follow. So we don't have to stay uniquely and sort of laser focused on their actual literal amount of substance use to be able to help them to make progress in reducing their substance-related harm. Also shows our more holistic investment in them as people. And then finally, we engage in discussions around safer use strategies and the relative risks of different behaviors that they're engaging in. So helping them understand, and that's why we do we elicit the story around their substance use, so we understand how they're using substances, what substances they're using, and that way we can drop in psychoeducation around how to engage in those practices more safely. And we do that wrapped in affirmations. So they're feeling good about the safer use strategies they're already engaged in, and then we kind of help bolster those efforts even more to be sure that they're aware of all of the different ways that they can take care of themselves. And this is really important, obviously, from a pragmatic standpoint. We want people to use substances more safely if they're out there using for themselves, but the families and the communities wrapped around these folks, that is really important. But also because a lot of these folks, don't think that they're worth saving. A lot of the clients that I work with, people say, well, you're not ready for treatment, so come back when you're ready. And they haven't been able to connect to services or providers that have indicated that they really care about them until they're ready, willing, or able to stop using substances altogether. So the message that you can provide people that you care about them, even if they're using substances, and you're willing to engage with them and help them even when they continue using substances, is actually a huge corrective emotional experience for many of the patients that we work with. So those are our three primary components. And we provide trainings on this harm reduction treatment. So if folks are interested in this, you can find my contact information at the end. We provide regular trainings on our harm reduction treatment and a day-long training. While I'm talking about what harm reduction treatment is, I also like to talk about what it isn't. This is really important for folks to hear. So harm reduction treatment is not any one of these modalities. So for those of you who are RCD counselors or substance use treatment professionals, you may have, you may use these things in practice. I also should put on here inpatient, IOP, outpatient, like weekly individuals or monthly individuals or aftercare programs. Traditionally in Washington State, according to state law, they've been stipulated to be abstinence-based. But that is the primary thing that all of these share in common, is that they are meant to move people towards provider-driven versus user-driven goals. And to date, those have either implicitly or explicitly been abstinence-based goals for people with substance use disorders. Sometimes people say, but motivational interviewing, though, that's not really a tough love approach, and it's not. It's a kinder, gentler way towards abstinence. And in fact, Bill Miller and Stephen Rolnick, when they created the first edition of motivational interviewing, it was actually intended originally to kind of coax people into attending abstinence-based treatment. That was actually the purpose behind motivational interviewing at its start. Later, they realized it worked pretty well as a standalone intervention. But still, even in the most recent edition of motivational interviewing, or MI3, as I like to call it, which is an excellent, excellent psychotherapeutic manual. If you haven't read it, I highly recommend it. But chapter 10 is devoted to when goals differ. And in this, Bill Miller and Stephen Rolnick note that therapists from a humanistic or existential orientation, you could read in their harm reduction, might object to the directional aspect of MI, whereby clients are intentionally guided toward what the counselor regards to be appropriate goals. So in harm reduction treatment, there wouldn't be a chapter 10. Our goals should never differ from the goals of patients. And over our many years of research, we really haven't seen that comes up very often that people don't have goals that we can get behind as clinicians. It's extremely rare. I can count those instances on one hand after thousands of interviews that we've done with folks and treatment sessions. And I spoke with Bill Miller last year around this time, and he said, what he thought was the spirit of compassion is very similar between harm reduction treatment and motivational interviewing, but it's that spirit applied towards a harm reduction end, which is fundamentally different from how MI has been applied traditionally. But all of these other modalities really are meant to, either in a gentler way or a more explicit way, to engage people in abstinence. So what is our mindset when we're engaged, when we're changing our practice or we're trying to integrate harm reduction into our practice, at least for certain patients or clients? We have to kind of rethink our mindset as clinicians to be more aligned with the harm reduction mindset that I was telling y'all about earlier. And this is our basic mindset as use reduction psychotherapists or counselors, which, by the way, I'm classically trained in this. So I spent most of my career standing in bathrooms watching people pee with gloves on. So I really do understand, and I really appreciate abstinence-based treatment, because for some folks, that approach is the thing that keeps them alive and keeps them on a pathway. So I don't want to take away from the value of these approaches in talking about this. I do want to just differentiate between an abstinence-based approach and a harm reduction approach. But our ultimate goal as use reductionists is abstinence. This is based on the belief that use and problems are in one-to-one agreement. So the idea that we have two spectra that we could think about. One is the use spectrum, and you want to go from, hey, a person's way down here on the spectrum, they're using a lot of substances, we want to move them down to 0 substances, right? So you can think of that as a spectrum. Sometimes with heavier drinkers, where you're doing an opportunistic intervention, you might say we could stop off at moderate drinking. But usually with people with substance use disorders, classically, we've said abstinence is the best way forward. The idea is this isn't just, thought about in isolation, right? The assumption is if the person's use decreases down to zero, so will their problems. And that's really what we're after. But what we found in our research, and a few years ago, I was commissioned by the National Institute on Alcohol Abuse and Alcoholism to do this review of studies all over the world on socioeconomics and alcohol use and alcohol-related harm. And I didn't know what I would find with this. I actually didn't know too much about the topic at the time. But what we found is in every single culture that we looked at that did studies around this all over the world, the dominant culture in the United States, that would be white, male, higher SES, well-educated, can use an awful lot of alcohol and experience relatively few consequences compared to more marginalized communities, communities of color, communities with lower socioeconomic status, particularly in communities that I work with more closely, for example, people experiencing homelessness, that those communities can use even a little bit of a substance and have extremely disproportionate negative consequences resulting from that. And that kind of goes back to what I mentioned before about mass incarceration disproportionately affecting communities of color, where even low-level drug offenses were disproportionately punished. So we see that really these two spectra aren't in one-to-one agreement. An example is with a lot of my clients who experience homelessness, they could stop drinking tomorrow or stop using substances tomorrow, but that wouldn't erase a lot of the very real socioeconomic impacts that are transactional between their substance use and their socioeconomic status that kind of go in circles and circles. So we really don't find, even for the most marginalized folks in our society, that this use and problem spectra are really in one-to-one agreement. So that assumption just doesn't hold true for folks who are outside of the dominant culture. Our stance as use reductionist is prescriptive. So within this stance, we believe that we know best about what the course of treatment, what the right course of treatment is, and what the goal is, and namely abstinence. Within this, the idea is the doctor knows best. So when we move towards a harm reduction stance, the goal changes to promote harm reduction. So we throw out this use spectrum altogether, and we focus in on harm reduction as our key. Now that means that can include abstinence as a person's goal or a person's trajectory, that they want to move towards abstinence if that is really coming from them, if that's something that we're not imposing upon them. That can be one pathway to reducing substance-related harm, but it certainly isn't the only pathway. And again, this is based on our understanding now from the research that risk of substance-related harm is variable, individually based, and again, subject to these larger geopolitical, societal, and community-wide forces. Our role as a harm reductionist then becomes a little bit different. It turns to be more predictive. We help clients assess the relative risk for substance-related harm, given the type of substances they're using, how much they're using, and then help them understand, bring the science to understanding their behaviors and how it can affect them so that they can move forward in a more scientifically informed way with their plan to reduce their substance-related harm. And in this stance, we believe the client knows better. The client knows better about their life context, and we are bringing our knowledge to the table and basically engaging in an exchange of knowledge bases, but not assuming that ours is more informed, taking into account the client's larger social and other contexts. So for this last part, I want to talk about why we engage in harm reduction practice, so why we have moved from our practice in abstinence-based treatment to a harm reduction frame. And again, I want to not take away from the importance of abstinence-based treatment in our treatment system. I think it is hugely important. I myself started in 12-step meetings when I was 16, and I have an intergenerational experience of very severe alcohol use disorder. I myself have stopped drinking and have been through many of the sort of typical treatment encounters that people experience, although I do not share many of the life circumstances and the severe socioeconomic marginalization of many of my clients, and I don't know what other people's experiences are like. I've experienced a little bit of this, but I know enough about our treatment systems, both from a personal perspective and also from a professional perspective and a research perspective, to know that abstinence-based treatment is really what saves people's lives and saves families in many instances. So again, I don't want to take away from that, But I do want to indicate that harm reduction can really broaden out the spectrum of clients that we can serve, so that we're not only serving people who are ready, willing, or able to stop using, but we're able to serve a broader spectrum of folks who could benefit from means of reducing their substance-related harm, even if they aren't ready to stop using altogether. And so I want to provide a rationale for why we moved our practice from a traditional and abstinence-only practice into a harm reduction practice. And again, I want to stress that harm reduction doesn't preclude abstinence-based goals. In fact, half of my clients here at the clinic, even though they didn't come into harm reduction treatment wanting to stop using substances, about half of my clients are currently abstinent from using substances, or at least certain substances that were the most problematic and the cause for their engaging with me in treatment. So it is not incompatible with abstinence-based goals as long as they are truly client-driven. So why we moved to harm reduction practice? Well, what we found was that traditional approaches could be disempowering. And as I alluded to before, I was engaged in traditional abstinence-based practice. And I was running relapse prevention groups many years ago in a Seattle-based treatment agency. And I wasn't working there. I was doing this in the context of a randomized controlled trial. And I walked into their break room where I was doing this part of what services they were providing at the time. And this was the sign that was on the break room wall. Our clients are very sick and they often lie to us. And I really thought, this was something that patients and clients couldn't see, but it was something, in the break room that kind of becomes the mantra, I guess, for a lot of counselors. What we hang up in our break room kind of defines us as a culture. I think this is really telling about how our culture views substance use and substance use disorder. So we have the disease model or the medical model. This is sort of the Western perspective on how we like to categorize and pathologize substance use and among other behaviors, obviously, but in this case, substance use behaviors to be a disease or an illness. And this illness is so insidious that it kind of causes lesions on your character, right? And this is where we have the disease model really closely entangled with the moral model of substance use and substance use disorder. So this disease is so insidious, this chronic relapsing brain disease is so insidious that it causes like these character lesions or character defects that cause people to do bad things, right? What I love about this sign is that someone wrote at the bottom in pen, and I swear it wasn't me, and sometimes they tell the truth. And I think that's really indicating a movement towards harm reduction. It's taking into account the nuance in the situation, that our clients aren't one thing or another, and they aren't just doing one thing or another. The system is more complicated than that. And I'd like to invite y'all to think about, when we think about clients lying to us, that's one way. That's a way you can view it from a certain vantage point. As a clinician who, might get annoyed that maybe a client is saying they aren't using when you ran a UTOX and you know that they are. But thinking about how the system may have shunted them into making that decision to tell us maybe what we wanted to hear. Perhaps we're the only person they could talk to about their substance use that week, and they're afraid to lose us as the one provider they can talk to. So they want to, because of social desirability reasons, they want to tell us what we want to hear. And that was a big reason that I moved away from actually abstinence-based treatment provision, because I was walking into relapse prevention groups and realizing over time that I was telling people what I wanted to hear. They were telling me what I wanted to hear, and then I was saying, thank you for telling me what I wanted to hear. And we all would leave, and I actually didn't really have the feeling that anything would change with anything. We had this sort of almost farcical transaction that I knew that's a good percentage of those folks would go out and were not necessarily fully engaged in the things they purported to be engaged in. But imagine that they have to do that in order to stay engaged in help and to stay engaged in treatment. If they want help, that is kind of the dance they have to do. There are other reasons. Some of our clients are mandated to treatment by judges, and if they don't go to treatment and report that they're abstinent, then they could go back to jail or prison and lose maybe their only means of livelihood or personal freedom. They might lose their kids if they're involved in children and families. So I invite you to think about what would you do if you were in a similar situation that many of our more marginalized clients are in to maintain relationships and to maintain freedom and livelihood and families. People have to oftentimes, quote unquote, lie to us. But I would say that a lot of the onus of the responsibility for that lying is really our interlocking systems of oppression that we are all, that many of our clients are kind of shunted around in. So just invite y'all to think about that a little bit. But that was one big reason why I moved away from abstinence-based treatment approaches, is I found that these approaches were disempowering to folks, taking much of the decision-making away from them due to system pressures. Also, we know that traditional approaches don't work for some. And when I say traditional approaches, I really need to change that to be abstinence-only approaches. So we know in working with one of the main populations I work with are people who experience chronic homelessness. And we know that in one population I worked with here in Seattle as part of the original 1811 Eastlake evaluation team. So we were interviewing the highest utilizers of publicly funded systems in King County at the time who had known histories of chronic homelessness and very severe alcohol use disorder. And some of these folks then ended up moving into 1811 Eastlake, which was one of the first low barrier housing programs where people could use on site that was aimed towards this population. When I was talking to them in interviews many years ago now, they told me on average they had been to treatment 16 times. So if our traditional treatment system was working for these folks, they would not have told me that they had been to treatment an average of 16 times. That was the average. That was on average. So there were some people who had been to treatment more. This is inpatient abstinence-based treatment. But I wouldn't have been sitting there interviewing them today. So for certain folks that we're working with who are experiencing this revolving door of treatment, our traditional programs are not necessarily working. However, a few years ago, SAMHSA started asking questions of folks through the National Household Survey on Health and Drug Use, drug use and health. And in SAMHSA in 2016, 21 million Americans needed treatment, right? They met criteria for a substance use disorder, or they had attended a treatment, substance use treatment facility in the past year. They were classified as quote unquote needing treatment. But only 2.2 million of these individuals received treatment. Of the 89%, so 89% of people needed treatment, met criteria for a substance use disorder, but did not receive it in the past year. They asked these folks if they felt they needed treatment, and 96% of those said they did not feel they needed treatment. Now, SAMHSA did not ask the obvious questions, which would have been, why didn't you feel like you needed treatment? And I've told SAMHSA they might want to add that question. I haven't heard back from them yet. But what we can assume is that our treatment system is not engaging 96% of the people who need treatment who aren't getting it out there. Now, that could be for various reasons, but when they did ask why people who felt they needed treatment and did not get it, they did ask those folks why. The number one reason wasn't, for example, insurance or logistic reasons, but was that they weren't ready to stop using substances. So we need to think about how our traditional treatment system is engaging folks and who it's not engaging and how we can better reach those individuals. What we also know about harm reduction approaches is that they provide an effective alternative for people who are not yet really willing or able to stop using substances. So for alcohol, when we talk about interventions that are applied at the community level, for example, Housing First or alcohol management programs, we know that these are helpful in reducing substance-related problems or alcohol-related problems, and also utilization of publicly funded services connected to severe alcohol use disorders, such as use of the ED, EMS, and jail systems. Housing First is low barrier permanent supportive housing. Alcohol management is something that's primarily been done in Canada, but is where doctors write scripts for alcohol to be administered at certain times throughout the day to maintain people who are very severely marginalized and using shelter services or supportive housing services who have alcohol use disorder to prevent them going into alcohol withdrawal, which if it moves on to delirium tremens, which is the most severe form of alcohol withdrawal, is deadly in 20% of untreated cases, 5% of treated cases, even medically. Through our research, we found that harm reduction treatment applied at the individual level is effective not only in reducing alcohol-related harm, but also reducing alcohol-related problems. In terms of other substances, we know that when we talk about that larger policy level, when large swaths of a country or state are covered with a comprehensive package of opioid substitution, what we now call medication-assisted treatment, needle and syringe exchange programs, and antiretroviral therapy, we find that the incidence of bloodborne illness transmission and overdose deaths decreased dramatically. In terms of large policy applications of drug decriminalization, either de facto in the Netherlands or truly legally in Portugal, and to a lesser extent on a more limited basis in some states in the United States when it comes to cannabis, we find that people are less criminalized, so they're utilizing fewer criminal justice systems in countries that have comprehensively decriminalized all substance use. There is also more substance use treatment attendance, and youth do not seem to be picking up substance use more in these countries. There's only one study I've ever found that came out of California that was a little bit back and forth about whether use among youth actually decreased, stayed the same, or it was a little bit sporadic. But the studies coming out of Washington State, Colorado, Portugal indicate that youth are not using more after certain substances are decriminalized. In fact, decriminalization regulation tends to make those substances less widely available. And then methadone and Suboxone are now the gold standard medication-assisted treatment for opioid use disorder. So instead of having people discontinue use of opioids, what we now do is try and maintain folks on opioids, but at controlled doses that are of pharmaceutical grade. And with tobacco, it's really actually pretty simple. Anything that does not involve smoking is a safer way of getting nicotine. And this is something that I have to actually do a lot more education around in my substance use treatment trainings, because there are a lot of myths about tobacco and nicotine out there. And nicotine doesn't cause cancer. Nicotine is actually relatively harmless drug. It's a very addictive drug, but it doesn't actually really harm your body. So anything we can do to get smokers to move away from smoking and move towards smokeless options, either smokeless tobacco, nicotine replacement therapy, vaping, snus, any of these safer options is going to be at least 85% safer, even with the dirtiest of our smokeless tobacco products here in the US, ranging to 99% safer with nicotine replacement therapy, 95% safer with vaping. So these kinds of things we know to be true, that reduces immediately cardiovascular risks. Nicotine, although it's a stimulant in some ways, it's a very complex stimulant, it actually doesn't instigate too much cardiovascular problems. The vast majority of the cardiovascular problems that people and circulatory problems people experience due to smoking is due to the smoke and the inhalation of smoke and how carbon monoxide is moved throughout the body. And certainly the vast majority of the cancer risk is potentiated by nicotine-specific nitrosamines that are very efficiently transmitted throughout the body in cigarette smoke, most efficiently transmitted throughout the body with nicotine smoke. And PAHs, or polycyclic aromatic hydrocarbons, which are the direct byproduct of inhaling smoke. So this kind of education, we've just found that when people know this and they can safely move towards other means of attaining nicotine, their risks go down very dramatically. And I want to go back to the harm reduction treatment that I kind of fleshed out before, specifically in a paper that came out last month in the International Journal of Drug Policy, which I'm happy to make available to folks. We found that when we talk to folks about how to reduce their alcohol-related harm, and we ask people what they want to see happen for themselves, and we help them track metrics that are important and relevant to them, we see a 71% reduction in alcohol-related harm, 66% reduction in peak alcohol consumption, 63% reduction in alcohol use disorder symptoms. That's the number of AUD symptoms people experience according to DSM-5. And even though we're not going towards abstinence at all, we wanted to do biochemical verification, and we found that there's a 20% reduction in positive urine tests. So some clients, even though we're not asking people to change their literal alcohol use in any way they don't want to, are drinking so much less that it looks like they aren't drinking at all. So that is a little bit about harm reduction today, introducing the main concepts and the rationale for harm reduction treatment. And I want to thank our many community partners who made this possible. Again, our specific harm reduction treatment for alcohol use disorder was co-created by community-based agencies, Evergreen Treatment Services, REACH, Homeless Outreach Program, and the Downtown Emergency Service Center here, the Dutch Sizzler Sobering Center, and the many folks on our community advisory boards, people with lived experience of homelessness and alcohol use disorder, who have worked very hard to co-develop these interventions with us. And I want to provide for y'all too, for consideration, different websites where you can inform yourself about what safer substance use looks like, self-help resources for clients. I can highly recommend these. and then literature on harm reduction approaches and psychotherapy manuals for clinicians and counselors as well. And I mentioned how important it is to talk about racial equity and social justice, so these are some resources on that. And if anyone has questions or wants to email me or find out more about the work we're doing at the HearT Center, you can check out our website or contact me via email.
Thank you so much, Dr. Collins. That was a fabulous presentation, loads of information, lots to think about, and we appreciate the resources at the end as well. I think we've had some questions come in, and we have a few more minutes. So I'm going to turn it over to Tavish to read some of the questions that have come our way.
Yes, I just wanted to echo Mary's thank you. Yeah, fantastic presentation, and HealthierHere is so fortunate to be able to provide this opportunity to our community. So we had a question come in from Siobhan Brown at Community Health Plan of Washington. Her question is, does harm reduction treatment require or encourage the use of MAT for substances such as opioids and alcohol, or is the inclusion of MAT a component of client choice?
Certainly everything is client choice, so we don't, in our practice, we don't mandate that people have to use medication-assisted treatments, but we talk to folks about the many different options of medications and devices that can help, help bolster people's, behavioral efforts towards substance-related harm reduction. So we like to give people a menu of options for sure.
Great, thank you so much for addressing that question. If anyone else has questions, please go ahead and enter them. We've gotten a few questions asking if we can share the slides with everyone. So Dr. Collins, are you comfortable with that? We will be posting the video of the presentation.
Yes, that's fine.
Great, thank you.
Yeah, so we will send the slides to everyone. Yeah, we still have a couple minutes if there are any other questions.
Any raised hands of folks who want to chime in? Good.
Yeah, so we got some feedback that folks love the shirt you're wearing in this last slide.
Well, I can share that if you visit the Harm Reduction Coalition website, which is one of the websites on there, they are a wonderful organization, started in 1993, and they do an excellent harm reduction conference every 2 years. It was this past October in New Orleans. They like to sell a lot of swag there, and you can order T-shirts off of their website. I highly recommend also the information on their website, particularly for injection drug users, getting off right, which is a slang term for using heroin, traditionally injection drug use of heroin, and really helps explain at every turn in that kind of medicalized procedure, frankly, how we can help our patients make safer choices about how they're using. So it's an excellent, wonderful coalition that I highly encourage folks to check out. It's a great conference.
Thanks.
Thank you. So there have been some more requests for the slides. So I just wanted to say again that we'll be sending that out to everyone who participated or registered for today's webinar. And now I'll turn it back over to Mary to wrap us up.
Yeah, I just want to say thank you again to Dr. Collins. Thank you for everyone who joined us this afternoon. We managed to start on time and finish on time. I'm very proud of us on this Thursday afternoon. As Tavish said, the slides will be coming out, and that is an awesome shirt you're wearing in that picture. And we will be in touch. We are not quite sure what our next partner learning webinar will be, but when we have it, you're all now on our contact list and welcome to join and welcome to forward invitations. So thanks from HealthierHere and thanks to Dr. Collins. Bye-bye.
Thank you.
Thank you. Bye-bye.
And